Thank you for joining the session today. I'm Dr. Gurdeep Kokri, and I'm really happy to be here today as part of CLEAR Week. So I'll be talking about post-intensive care syndrome today. But before I do that, I'll start with a bit about me. So I'm a GP by background. I work in London, Southeast London, and I've been working with 33N and CLEAR for just over a year now. I initially became involved with CLEAR as I was quite attracted to the idea of clinicians leading quality improvement within the NHS. And so far, it's been really, really rewarding working with the wider team. And do feel free to connect with me, after this talk on LinkedIn. My tag is Gurdeep-K. Right, so today's session is one I'll be facilitating. It's a condensed version of our GP PICS educational session. So this is focused on spotting and managing post-intensive care syndrome, or PICS, in primary care. And I, for one, hadn't had much experience of PICS at all as a GP, and I suspect this is the same for many of my colleagues across the country. So it's most definitely improved my practice in recognizing and managing this important syndrome. So the session will include a series of short educational videos, and the aim of today is really to showcase some of the exciting work we're doing here at 33N and CLEAR. And I think because there's only a few of us, we can keep it quite informal. So if you have any questions, do feel free to switch your mic on and you can ask me as we go along. Right. So I'll start by talking about the background and how this PICS project came about in the first place. And that all stemmed from our Circle course, which some of you may or may not have heard of. So back at the start of the pandemic, 33N clinicians came together with our partners at Brunel University to deliver the COVID-19 ICU remote learning course. This was a one-day course delivered remotely for us to allow scalability, but also safety given social distancing restrictions at the time. The course rapidly trained an abundance of staff who were redeployed to ICU so they could undertake their new duties safely. And it was a huge success. Subsequently, we were highly commended at the HSJ Awards and also won the Innovation Award from the Intensive Care Society. So this really got us thinking at 33N and CLEAR. So we work in a multidisciplinary team of practicing clinicians, educators, and data scientists. And the Circle course prompted us to recognize that there's probably going to be an increased burden of post-intensive care syndrome following COVID-19 ICU admissions. And this would likely present to primary care, where clinicians would need to look after these patients in months and years to come. And as I previously mentioned, it's not a syndrome we see very often. Hence, the GP PICS project was born, and we're aiming to raise awareness of post-intensive care syndrome in primary care. The basis of the project follows a similar principle to Circle. So it's using asynchronous remote learning so we can make it really scalable and reach the widest possible audience. Our GP PICS offering combines a short 30-minute educational video with an easy-to-read infographic, which together will be facilitated with local ICU clinicians and primary care clinicians. So although we're making it quite scalable in terms of the video and the infographic, we are going to have some local insight when we deliver this session, because we all know that pathways can vary significantly in primary care throughout the country. So having that local knowledge really will amplify what we're doing here. Right, so that's my brief introduction, and now we'll move on to sort of taster version of our session. So this is basically showing how this small idea after the Circle course turned into a really tangible product, that we're now ready to deploy. And the 4 key questions we wanted to answer are listed here. So how would a primary care clinician identify PICS? How would they assess for it? How would we support patients? And lastly, what specialist help is available? Right, so we'll kick off with our first video, which is an introduction to PICS, which is about 6 minutes long. So sit back, relax, and enjoy the video.
Hello, and welcome to this educational session on post-intensive care syndrome, also known as PICS. We have brought together experienced members of the multidisciplinary team to talk about how they identify and manage patients with PICS. By the end of this session, we'll have covered what to look out for in primary care, how to assess for these features, how to support patients with PICS, and what specialist help may be available. As a syndrome, PICS has features which are physical, psychological, and cognitive. We will use this framework to structure this session and will share with you an infographic that's been developed for general practice to help support you with identifying and managing these patients. So around 20 or so years ago, various intensive care medicine clinics were set up, and what they found was that for many of the patients that we were seeing after their hospital discharge, the journey of recovery was not complete. And in many ways, their journey had only just begun. Patients were starting to try and rebuild their lives, to develop back towards the quality of life to which they aspired. To many of the clinicians who began this service, the degree of difficulty that patients were experiencing was startling. But we now know that the challenges that they face on their recovery can be very common. Relatively recently, colleagues in North America started to use the label post-intensive care syndrome to try and draw some of this together. It is not a term that all clinicians are united around. However, many patients find it useful to have some label that they can apply to themselves, which conceptualizes the difficulties that they're having. What we have found is that many patients have a whole variety of unexpected consequences, and not all of them fit in particular boxes. Some patients will have physical issues, such as skeletal muscle wasting, joints that don't function as well as they did previously, and possible problems with nerve function. Some of them will have psychological problems, ranging from difficulty in doing the mental tasks which people had come to regard as routine, to significant depression and anxiety and post-traumatic stress phenomena. Many patients will complain of difficulties with their short and medium-term memory. So substantial challenges await the person who's coming home for a prolonged stay in intensive care.
Being critically ill is not like any other illness. Due to COVID-19, critical illness in ICU care has a higher public profile than ever before, but there is still a lack of understanding about what it truly means for the individual and for their families. It is most likely that the critical illness was unexpected, and usually there is no time to prepare or understand what is about to happen. The patient usually will be too unwell to participate in any shared decision-making about what treatment is needed. They and their families are thrown into an alien world. For the patient in ICU, they are likely to experience confusion, delirium, and be unable to communicate. They may be paranoid and terrified from delirious thoughts, which feel very real and often won't know they are in hospital. Treatments and care needed can feel brutal in this confused state, such as the regular clearing of tracheostomy tubes, which can often make people gag. Sleep can be difficult to come by too. There is often constant noise in the unit, machines alarming, for example. So many elements of ICU care can contribute to this profound sense of unreality and disorientation, such as the lack of distinction between night and day, being treated laid on your front, and staff wearing full PPE. And in the current crisis, patients may be experiencing all these things without the comfort of their family with them. Being discharged from hospital is not the end of the story for patients. Life has been turned upside down. Patients may have very distressing memories from their ICU stay and often not understand what was true and what was imaginary. They may not understand what treatment they have needed. They are likely to have new physical, psychological, and cognitive problems. Quite often, patients will have minimal information about what to expect in their recovery. They may not recognize which symptoms are a result of their illness and will get better, and which symptoms need urgent medical care. Fundamentally, their body may not be doing what it normally does, and it may feel like they have to relearn how to walk, how to breathe, eat, and live again. They are likely to be exhausted. There are a myriad of other possible after effects. For example, hair loss, skin problems, memory problems, breathlessness, being unable to sleep. Often it feels like there is not one area of life that has not been affected. Their recovery is also likely to take a significant amount of time, 12 to 18 months, and sometimes life is never the same again. Patients can feel very isolated and lonely during their recovery. A holistic assessment of how they are, physically, cognitively, and psychologically, and referring to services when they need it. GPs are ideally placed to support patients going through these difficulties and signpost to appropriate resources. For example, good quality information. This will help patients understand what has happened, what to expect, and what will help their recovery. Experienced input. The opportunity to talk with someone or with patient support groups who truly understand the after effects of critical illness. This will help them understand what to expect, what is normal, and what will improve in time. Also, to know what they can do to help themselves during recovery and what needs specialist attention.
So that was our introductory video, and I think it speaks for itself really to highlight how important post-intensive care syndrome is and how we need to be aware of it in primary care, because we're likely to see a lot of these patients in many months. You know, the recovery 18 months onwards, so we may be seeing these patients present, you know, much later following their ICU admission. So we're going to move on now to listen to some experts regarding the physical symptoms. So the next video is about 9 minutes, which takes a deeper dive into the physical aspects of PICS.
We will start by considering some of the physical features. One very common feature that people talk to us about is how weak they feel following an intensive care admission. We know from fairly detailed research that for every day in an intensive care unit, for the first 10 days of stay, patients tend to lose 1 to 2% of their useful skeletal muscle. This is probably due to a combination of difficulties in both maintaining nutrition and metabolic mismatch. It's a pretty consistent finding, and the loss of skeletal muscle causes functional limitations. Patients can be very substantially fatigued during the course of their recovery, and that can be very distressing to people, especially when they're trying to rebuild their lives, and often for younger people when they set themselves unachievable physical goals, such as getting back to the gym. This can be a significant source of distress. We don't have any clear treatment other than very good supportive and nutritional care on the ICU, and we can't prevent this happening for patients. Often, patients will have joint stiffness as well. That is perhaps not surprising because they are not using their joints normally, and there is a risk that the joints are put into positions which aren't mechanically very comfortable. During the last year or so, when we've been looking after patients with respiratory failure due to COVID-19, often we've had to look after patients with them lying on their front, where we have to be very careful about both their joints and nerve damage, particularly around the brachial plexus. These physical consequences, in addition to the consequences of interventions such as lines, endotracheal tubes, and chest drains, can all be problematic.
Early rehabilitation in critical care is essential to reduce the complications associated with post-intensive care syndrome. So, what should I look out for? Despite early rehabilitation, there's often persisting reduced joint range of movement, muscle wasting, reduced exercise tolerance, breathlessness, pain, and peripheral neuropathy. These can be seen in patients for months and sometimes years after their discharge from hospital. Specifically, intensive care unit acquired weakness is defined as clinically detected global muscle weakness, where there's no other contributing etiology other than the critical illness itself. It presents with symmetrical limb weakness. So how can I detect this? Well, I usually carry out a basic shoulder assessment, which includes functional range of movement and muscle power. But simply looking at the patient and seeing if they've got any global muscle weakness is enough to detect ongoing issues. And this is important because it can lead to falls risk. It's useful to ask the patient if they've noticed any changes in sensation or the presence of pins and needles which might suggest a peripheral neuropathy. Reduced exercise tolerance can be described in a number of ways. Patients may state they're unable to walk as far as they could before. They may say things like, I've gone back to the gym but can't manage my previous programme. I can't return to work because I feel too weak. Breathlessness is also commonly experienced. Patients often describe being breathless when carrying out activities like climbing the stairs, or that their breathlessness prevents them from doing what they previously could do with ease. New breathing pattern disorders may also be seen. These often manifest as breathing through the mouth rather than the nose, breathing in the upper chest over abdominal movement during breathing, and yawning and sighing. This is something that you could consider on examination. Well, if a patient's been identified as having weakness whilst they were in the hospital, they should ideally have been given an individualised exercise programme to continue with at home. If the patient presents with severe muscle weakness and reports of new problems or a movement deficit or restriction which are impacting on their ability to carry out tasks at home, a community physiotherapy referral is recommended. If the patient presents with mild and moderate weakness, there's a number of online resources that you can direct them to. If you find that your patient has been having falls, try and explore the mechanism of that fall, and that will help to guide your future management. This may include further medical assessment or referral to a local falls team or community therapy. Breathlessness, if present, can be graded in terms of severity using the Medical Research Council breathlessness scale and used to guide referral to respiratory physiotherapists or pulmonary rehabilitation programs if no underlying pathology is suspected. If there is a new breathing pattern disorder, a respiratory physiotherapy service would be beneficial as well.
Critical illness will impact on patients returning to their usual daily activities, and this may be related to post-intensive care syndrome. So what do we need to look out for in clinical practice? Some people are unable to walk, unable to wash or toilet themselves and require full care, whereas others may not present with any difficulties in these more basic tasks, but may experience difficulty in caring for their children or returning to work. Many of the difficulties people have are hidden. One of these is fatigue, which is common following critical illness and can continue for many months. Fatigue can have an impact on ability to think, sometimes described as brain fog, as well as physical ability to complete day-to-day activities. We can ask about patients' ability to complete their daily activities and ask them to compare this to their baseline prior to admission. In terms of assessing for fatigue, we can ask about sleep hygiene and any sleep difficulties. We can use a screening tool or a standardized score such as the fatigue severity score, and can be useful if you identify any problems from simple questioning. Patients can repeat these themselves weekly to monitor improvement and identify any triggers for exacerbations. We can help a patient help themselves, first of all, with activities of daily living, or ADLs. We can encourage people to write down what they're doing day to day before they became unwell and what they are able to do now. This may help them recognise progress and may possibly identify triggers. They can identify and prioritise activities most important to them. We can use goal setting through outlining small steps to reach a larger goal. With fatigue, particularly in the early stages of recovery, it's important that patients have proper rest. Make sure to encourage good sleep hygiene as well as several rests during the day. They should try and maintain a routine and set times for sleep, although at first they may need to sleep in the day. They should wean off this to allow good, effective sleep at night. Rest needs to be both physical and cognitive. Let patients know that lying on the sofa watching TV or playing with their phone may seem like rest, but concentrating, listening, or thinking can be more fatiguing than movement. The recommendation is for complete rest during these periods of time for 10 to 20 minutes, possibly using calming music or meditation recordings to support this. Pacing is a helpful technique in which one balances rest and activity. This involves breaking up each activity with rest periods, but also resting both before and after an activity. It's common for people to try and power through or to pace an activity, but then rush straight on to the next activity due to the demands of the day, so scheduling can help with this. If self-help is not assisting recovery enough, or a patient has complex needs, then a referral to a community occupational therapy service or fatigue clinic may be beneficial. There's a useful leaflet to help patients to self-manage their fatigue. This is titled How to Conserve Energy, published by the Royal College of Occupational Therapists.
Right, so again, I think some really useful tips there from Tom that can quite easily be deployed into a primary care consultation, and a useful leaflet that he mentioned at the end there as well, which is worth looking into. Right, so we shall move on to the next video on physical symptoms, which is about 7 minutes long, and then we have a few shorter videos to finish off the session.
We will now talk a little bit about nutrition. Many patients find that their appetites do recover fairly quickly, but there is a subgroup of patients whose appetite is dysregulated into their time at home. Research on this suggests that the dysregulation of appetite control mechanisms is not that uncommon. The appetite tends to switch off very early after people start eating. So they experienced hunger, start eating, then they experience this phenomenon called early satiety. That can be problematic if people are expected to get back to 3 square meals a day. Often a strategy of more frequent but smaller meals tends to match up with this a lot better, but we'll hear more about this in more detail from a dietitian.
Despite our best efforts, nutritional status often deteriorates significantly during and after a patient's ICU admission. Due to this, muscle wasting on ICU can be a rapid process, and this lost muscle can take months or years to regain. So what should I look out for? Loss of appetite, which can be several weeks or months to recover after ICU. A reduced appetite usually results in a reduced oral intake and thus impaired functional recovery. It's important to ask the patient about their present appetite, finding out about how this compares to pre-admission and how things have changed since discharge home. They can then be asked about their intake over the past month and whether this is more, less, or about the same as normal. Patients might try to stick to their normal meal patterns but are restricted to smaller meal portions or not finishing full meals. It is then very important to ask about or listen for specific barriers or problems that are stopping them from eating normally, including the following: nausea, vomiting, diarrhea, constipation, swallowing issues, taste changes or no taste, dry mouth, pain, ask for details, feeling full easily, fatigue. Others include low mood, financial issues, dental issues, etc. Physical symptoms, weakness or breathlessness. Try and address a cause if found. Where you detect significant changes in muscle, weight, body composition, appetite or intake, I would strongly recommend using the ICU Steps and British Dietetics Association resources titled Nutrition at Home After Critical Illness and Tips to Help Eating Problems After Critical Illness. These are both free to download and an excellent starting point to improving patient understanding and overcoming the most common barriers to good nutrition during this important window for rehabilitation. In more serious or persistent cases, I would recommend that you refer to your local dietetic services. It's important to be aware whether the patient is already on any oral nutritional supplements has a new stoma, for example, jejunostomies, ileostomies, or colostomies, or receiving any of the nutrition non-orally, for example, tube feeding or parenteral nutrition. In all such cases, they will usually already be under the care of a dietitian, but please check, and if not, please refer to your local dietetics team.
In the context of PICS, GPs will commonly come across problems relating to voice, swallowing, cognition, communication, and airway issues. These are common in PICS and can persist long after discharge home. Let's start by outlining the reasons these problems arise. Firstly, intubation trauma to the larynx from prolonged or even short periods of intubation can cause vocal cord palsies, granulomas, laryngeal hypersensitivity, and even stenosis. So patients have problems with their voice quality and protecting their airway when they swallow. This causes aspiration, scarring, or vocal cord palsies, meaning some may still need a tracheostomy. Secondly, due to breathlessness, their voice lacks breath support and is very quiet, or they may struggle to synchronize breathing and swallow, so inhale or aspirate foods and fluids into the lungs. Neurological problems and long-term muscle weakness can cause quite severe dysphagia to the point where patients are unsafe for oral feeding and may need modified diets or alternative feeding methods like a PEG. Fatigue can also affect the voice, the speech and swallowing with difficulties chewing, for example. COVID itself can cause additional laryngeal and altered taste complications. Look out for dysphonia. Be aware of altered voice quality. Patients might report that they're struggling to be heard, or they can't sing anymore, or their voice tires and fades during the day. Also remember, our emotions and voice are closely linked, and traumatic experiences and anxiety can cause voice issues. Dysphagia can present with recurrent chest infections. It might be worth ruling out aspiration pneumonia as a cause, and other common signs like coughing on oral intake, struggling to chew, foods getting stuck in the throat, or even avoiding certain foods. These need further investigation and referral to SLT for a swallowing assessment. Signs of a cognitive communication difficulty would be patients finding it hard to make sense of what people say, expressing their thoughts and feelings in words, having difficulty reading or having a conversation, and look out for chronic cough or noisy breathing, which could indicate laryngeal hypersensitivity or airway issues. Obviously, signs such as stridor need urgent medical attention, but less urgent issues may need ENT or specialist SLT ENT airway services if you suspect inducible laryngeal obstruction or chronic cough, for example. For voice problems, encourage patients to keep hydrated, to use gentle steaming. Avoid throat clearing, medicated lozenges, smoking, or vaping. Reduce vocal fatigue by advising against talking over loud background noise, shouting and singing, and use more text-based options instead. Monitor chest status for signs of an undetected silent aspiration issue. If they're on thickened fluids, ensure that they have an adequate supply of thickener. And obviously refer to SLT for an in-depth swallowing assessment, as the patient might need a video fluoroscopy or nasendoscopy. You can find some fantastic advice on various websites. If you're concerned about any voice, swallowing, communication, or airway issues, please don't hesitate to seek advice and refer to SLT or SLT ENT joint clinics or specialist airway services.
Great. So yeah, again, that video highlighting nutritional aspects within post-intensive care syndrome. We have a few shorter videos to finish off the session, and then we can sort of have a discussion or take any questions. So this next video is focusing on COVID-19, obviously a very important area for GPs at the moment. So it's about 2 minutes long.
So what might you expect to see in patients after COVID-19? So this is something we're all still learning about, but we've now looked after large numbers of patients who've had COVID-related stays in intensive care. We've seen a whole variety of patterns of recovery, which have ranged from the unexpectedly excellent to the not very good. The sorts of things that patients have talked to us about have been fatigue, which many intensive care survivors experience, but it does seem to be particularly common in the COVID survivor. This can be really significant episodic fatigue, which gets in the way of recovery. Often patients seem to have difficulties with breathlessness, which is sometimes because of a mismatch of the ability of the respiratory system to meet the skeletal muscle requirements for oxygen demand and CO2 removal. And that may be because the muscles are wasted and inefficient. But in COVID, it's also possible that there's been some long-standing issues in the lungs. And in fact, most trusts have now set up specific services to screen patients for long-term consequences of COVID in the respiratory system. There's also a small number of people who may have suffered from pulmonary emboli, and that may contribute to this breathlessness as well. Some COVID patients may have had episodes of acute myocardial ischemia, and although hospitals are attempting to catch these individuals with their post-discharge screening systems, it is possible that some may have slipped through the net. Other people will have odd neurological phenomena, for example, sustained nerve damage due to positioning while they were in intensive care. But there does seem to be something unique that COVID does to the peripheral nerves as well. Many patients, even those who haven't been into hospital, complain of these odd neurological phenomena, paresthesia, pain and numbness, all sorts of odd things. And we're certainly no longer surprised by patients coming in with these sorts of symptoms. The main things that we would want to identify is people who have had damage to nerves where there may be some specific requirement for treatment. Many patients will also come home on drugs that they weren't on before they went into hospital. And numbers of patients will be on anticoagulation that they weren't on previously. Usually this is because there's been some evidence of pulmonary emboli.
Great, so we'll move on to the final couple of videos, and this one is one that really resonated with me about the importance of PICS to the families of patients and how there's a wider effect on those loved ones. So I'll kick off, it's about a minute long.
Before we finish, I just want to mention the families of those who have had a critical illness. Having a family member being so ill is a very frightening experience. During the COVID pandemic, they also may not have been able to be by their side in ICU, which adds to the distress. Now that their relative has returned home, they may have become a full-time carer. Many family members experienced family post-intensive care syndrome. This can include anxiety, depression, and sleeplessness, amongst other things. There may also be a significant impact on financial security, as family members are drawn into informal caregiving roles and have to make adjustments to their own professional and working lives. They too need information and the opportunity to talk with someone who understands what they have been through and what they're experiencing now, with referral to specialist help if they require it.
When someone's in hospital, all they can think about is getting home. Once at home, recovery is just as challenging. The person and their family begin to process what's happened, and recovery is slow and non-linear. People will need help to understand their limitations so they can adapt and set realistic goals which enable them to measure progress, build confidence and resilience, and return to doing what matters to them. Consider a referral to occupational therapy and community rehab services when people require more than signposting to advice and self-help tools.
So now you've had the opportunity to hear more about what patients experience after critical illness. I hope it's been useful and thought-provoking. These are patients and families who need help to recover after critical illness, and the first step for this is for healthcare professionals to have an understanding of what they've been through in the intensive care, and so that they can recognise the after effects. Thank you for listening, and for your interest in helping these patients. It's very much appreciated.
Great, thanks so much everyone for watching the videos, and hopefully you've taken home some key messages from those. This is our infographic displayed here, which is going to be disseminated alongside the educational video component as a quick, easy to read resource with the key sort of symptoms to look out for in primary care, alongside some screening questionnaires and resources and leaflets for patients, as were mentioned in the video. Right, so I hope this taster session has got many of you thinking about the importance of recognising and supporting our patients following critical illness. Overall, we need to use a holistic and individualised approach, and support from the multidisciplinary team is always at hand. Some localities even having specialist post-intensive care outpatient clinics. And even the small things, as simple as if you spot a discharge summary, that someone has been in intensive care or had a prolonged admission, maybe picking up the phone or inviting them in for a sort of routine checkup might be the first step in recognizing any sequelae of critical illness. So thanks to everyone who's taken the time to attend, and if you do have any specific questions, we can go through them now, or you can reach out to us and the wider team after the talk as well. I would also like to thank all our subject matter experts who came together to help with this project. They've come from all over the country. We've got Wales here, London, and so on. And also we've had some former ICU patients who have kindly contributed to our video. And secondly, a huge shout out to all our in-house consultants who made this all possible. Great. So I think the last thought I would like to share is away from the PICS project itself, but around the wider sort of 33N CLEAR ecosystem. So hopefully this has showcased sort of what kind of work we're doing. And for me, being part of CLEAR has really given me an opportunity to turn simple ideas into reality with some freedom to be creative as well. And I think this is something that's quite unique for clinicians, because usually we sort of do our day-to-day clinical work, but we don't take that. We don't have the opportunity to step back and try something different. So for me, it's on a personal level, it's given me new skills and helped me to diversify my capabilities while still retaining the focus on patients and the NHS. So yes, please do connect with us online or on LinkedIn, and we can continue our conversations. And a last final little plug for CLEAR Week. So this is just the start of CLEAR Week, and we're celebrating innovation and transformation within the NHS. We've got a whole host of fantastic talks. So if you scan this QR code now on the screen, you can have a look at the timetable, and if you have some availability, you can sign up to some more sessions. Great. I think we will pause there. So if there's any comments or questions, I can take those now.
Hi, Gurdeep. Charlotte here. I did have a little question I posted in the chat. Earlier on in one of the videos, it was said about how COVID has raised the profile of critical care. And I was just wondering if you or maybe anybody else on the call had any insight on the effect that has had on maybe giving care, giving care at all.
Yeah, no, I totally agree. And I think COVID has really brought this to the forefront of our practice. As a GP in the past, you may not see many of your patients go into ICU, maybe one or two per year. And this is brought really to my attention. So when I see a patient who's had an ICU admission, I'm going to take a proactive step to bring them in or have a conversation with them to see how they're getting on. And also that the other point that hit home with me was the families and how they can be affected. The last thing I'd say is also what's come around is the coding aspect. So when patients are discharged from hospital, to make sure they're being coded as ICU admissions, so the wider clinical team can be aware. So we were doing some work around that actually, and hopefully this will spin off into a bigger project to raise awareness of accurate coding of ICU admissions. Great. I don't know if it doesn't look like there's any other questions. We can probably bring it to a close if there isn't, and you can, as I say, you can reach out to us to connect if you have any burning questions after this.